3, 2, 1. Hey guys, welcome back to the FOAMfrat podcast. We're going to talk all about trach management today. Sam is putting out a blog. It's going to go out tomorrow. We're recording Friday. No, we're recording. Yeah, it is Friday today. It'll
It's
be going
Friday.
out tomorrow morning, and it will discuss 3 things that you need to know about managing trachs. And I read through that blog this morning, Sam, and I thought it was really well done. I like the case you started off with. One of my first experiences with a trach was a patient who was awake on the ventilator. They had a trach, and all of a sudden they started going like banging on their chest like they can't breathe. The pulse ox started dropping. And I'll tell you what, man, there's nothing more scary than seeing somebody who's awake and can't breathe, becoming hypoxic, and you're trying to troubleshoot what is going on. Why is this happening? Is it a ventilator setting? Is it mucus? Is the cannula like jammed up against something? And you need to have an approach to this type of situation. You need to have a checklist that you go down because there's a ton of human factors that come into it. So talk about the case that you had. It was a CPR in progress and the patient had a
Yeah.
trach, right?
Yeah. So we got called out to intercept with a crew that was currently running a code. It was at a nursing home. So, I mean, of course, you're going to see elderly patients. Sometimes they have tracheostomies and whatnot. And this patient did. And so we're walking down these big old nursing home hallways and we're second crew in. So we're just hauling all of our equipment in. And, you hear stuff like defibrillators charging or somebody giving order. And so it's like you can hear these sounds of a code running. And you could hear, that sound that the bag valve mask makes. Sometimes you squeeze it, and as you let off the duck bill on the inside, it sometimes makes that like quack sound as you
Mm-hmm.
release, and it kind of like flutters
Yeah,
sound at
yeah.
the end. And it was kind of like that, but not exactly. And that usually happens as you release the bag valve mask because it's closing and it's rerouting and whatever. But this was happening during the inhalation phase, and it was kind of making that a similar noise. And once we approached the patient, I realized that I'm like, that's a really strange noise. I'm like, I wonder. My first thought is I wonder if their cuff is inflated. Then I saw they didn't even have a cuff, so I was like, oh, that's probably an issue. And then so we inspected it. It had an inner cannula in it, and it was fenestrated, which means that it had holes in it. Which I'm sure we'll touch on why a patient would even have something like that. Seems counterproductive. But that meant all the air was coming out of the mouth, and so that noise we were hearing was essentially like a reverse snore. Like it was I called it like a mouth fart in in the blog, and it was just the tongue rattling against because they're doing chest compressions, so lots of pressure in the chest, and so obviously like where's air going to go? Is it going to go towards the chest that has a bunch of pressure in it? Or is it going to go straight out the mouth? Obviously it's going to go straight out the mouth, so the patient wasn't even receiving ventilations.
Yeah, that's a scary situation, especially
Mhm.
because you don't have a cuff. I mean, if you have a cuff, you
Mhm.
inflate the cuff and you can utilize that. And so my first thought would be like, oh, well, maybe, I can just somehow cover that up and intubate through the
Mhm.
mouth or just intubate through the mouth.
Mhm.
And in this case, the air was escaping through the mouth. But in some cases, there's not even that connection between the mouth
Mhm.
and the trachea. It's completely rerouted. And so thought the blog was great. You walked through like the very beginning, the Jackson
Mhm.
trach, and I'll throw that up real
Scary.
quick. Yeah, this thing is this looks medieval, man. Look at this thing.
Yeah, it is. I mean, you're looking at a machined piece of steel right there. So that's the obturator on the bottom that blunts the tip so that you can put it into the stoma without, wrecking the stoma like crazy. So it blunts the tip and then you can put it into place. But yeah, these things, I think that maybe some of them, as those 15 millimeters adapters became more popular, I think some of them did have an adapter on them, but the most of them that you look up do not have an adapter on them. So kind of when we go through each one of these, as you become more familiar with the different types of trachs, you kind of form a doorstep assessment and you start looking for a few things. And if you see a shiny metal trach, you're in trouble.
Yeah, how would you even bag somebody with that?
You can't. That would be a swap. That would be a swap for sure.
Could you put an ET tube in it?
You have so much airway resistance with that. I
Because
don't
what
think
is
you'd be
that
able
internal
to.
diameter? I mean, would that take a? I don't even
So
know.
that's one thing about those Jackson sizes is because they're not very thick because obviously it's metal, it's rigid, it doesn't have to be very very thick. Um, their sizing is a little bit different. I put in the blog, there's like coding on each
Yeah, I saw
tracheostomy,
that.
and the original Jackson size is actually used as a reference. And so I think the Jackson size is always a little bit smaller, if I remember correctly, because I think if it's like an 8.5, usually the Jackson size is 8. I'm not real clear on how that works, but it still is used as like a unit of measure against current tracheostomies. But yeah, you'd probably have to put such a small tube in there that you'd probably run into like some serious airway resistance issues.
So if you run into one of these, you just need to pull it out and put an ET tube in.
If you have to use any kind of positive pressure ventilation. And I think that's one thing to realize. We will talk about all these different kinds of trachs and stuff, but if they don't have a problem, if they don't have a reason to receive CPAP or BiPAP or positive pressure ventilation, you don't have to do anything with them. You can just treat them like a normal trach. But yeah, the problem comes in when you have to provide some kind of pressure to the airway. You want to know, is the airway going to hold the pressure or not, or is it just going to leak out somewhere?
So like an ankle fracture, are you running in and ripping this thing out and putting it?
No, man. No, we're gonna leave it. It'll be cool. But the cool thing, like I do think that tracheostomies, even though I bring out all this stuff in the blog, and we'll cover troubleshooting them and stuff. It is kind of reassuring to me. Like a tracheostomy makes me feel pretty comfortable, because what's the most invasive thing that you could possibly do to somebody is probably like a crike. Just about, the crike
Mhm.
is like a very invasive thing, or cutting into any kind of front of neck access.
Yeah.
And so if they already have that, it's like a big, like you've already reached the end of your algorithm and you have this hole in the neck, and now you can just troubleshoot it. So to me, it's like you shouldn't, unless it's a very strange circumstance, like you shouldn't have to perform an RSI. You shouldn't have to perform laryngoscopy in the vast majority of cases. And so it's kind of nice as long as you can troubleshoot them, because one of the most invasive things that can be done is already done.
Mhm. All right, well, let's look at this one. This is the other one. This one has no inner cannula, so
Right.
this kind of reminds me of like the per trachs or
I
like
think
the.
that's what that one is.
Is that what
That
this
I think
is?
that picture I used, it might be the one from the perch rig.
Look at
If
that
not,
pilot balloon. That pilot balloon looks like it's getting ready to blow up any second now.
yeah. But actually, there's an interesting thing about that particular pilot balloon is it's more rectangle shaped. It's stretched out, which a lot of them are not. I talked about that a little bit in the leak ventilation section. But yeah, so that was the next thing that came out, was essentially, okay, we're not going to use metal anymore. Why don't we try using plastic, and then plastic, and then plus you were able to use the rubber or whatever they PVC or whatever they use to make that cuff. And so now all of a sudden you have these replaceable, disposable things, and you could fill them up with air. It's essentially, that is the most simple, almost the most simple form of what we think of with the tracheostomy. Is it's like a little ET tube. It's got a
Hmm.
flange on it. It's got a connector. It's just like a little short, rigid ET tube. Very simple to think about that one. Not a lot of moving parts on it.
But if something happens, you got to remove the whole thing. If you get some
Mhm.
big, I mean, you could try to pass like a suction catheter, or people talk about moving bougies through it. I know you
Mhm.
warned against causing some damage to the trachea by trying to
Mhm.
car ramrod a bougie through it. But
Yeah.
um, yeah, so this one here is very simple. It's got that 15 millimeter adapter on it,
Mhm.
and it's got a cuff on it. And you
Yeah.
said if you're not sure if it's cuffed or not, just look for that pilot balloon. If there's
Mhm.
no pilot balloon, then that means there's no cuff. And it's simple, but that makes a lot of sense.
Yeah, that's one of the things. Like I teach a class about this in the refresher for a live class we go through. Actually, I think I have recorded too, and we go through kind of like a doorstep assessment as of one of them, and just to notice what that looks like. And so that's one of those things you want to be able to just recognize real quick. Look at a tracheostomy. Probably the first thing you want to look for is, does it have a cuff? Does it have a pilot balloon that's hanging off there? Because if it doesn't, you're already like, okay, uncuffed trach. Now I'm thinking the only way I would be able to ventilate this patient is if they, with that trach, is if they don't have a larynx. So
Hmm.
that would be an issue. But I'm sure we'll show a picture of that. But yeah, so then those became the problem with those things was that how, let's say that you're the tracheostomy, you have this trach in, and like, are you cleaning it every day? Are you taking it out and like
Like your
running a cleaner?
dentures. Yeah.
Yeah, like, what do you do if you have, a bunch of secretions in there, it starts getting slimy? That's a real issue. So cleaning those things is a problem. So that's when the disposable or sometimes replaceable inner cannulas came out. So like this one right here, this has the 15 millimeter adapter on it. So you have to have that 15 millimeter adapter, that inner cannula in there, which shields the whole inside of that thing. You have to have that in there to even use any kind of positive pressure ventilation. So this is kind of what you want to see. You want to see an adapter, and you want to see a pilot balloon hanging off of there. That's usually a pretty good sign that like, oh, okay, things are going my way on this one. Like this should be a pretty usable trach for like no matter what we have to do with this patient, as long as it's working.
I went an embarrassingly long time before I knew that there was an inner cannula in those, because I remember patients having like tons of secretions coming up and I'd be trying to suction that out,
Mhm.
and you could just completely remove that inner cannula. Well, but here's my question. What would you do to like clean it out? I mean, would you take some saline and just try to,
Mhm.
is there a certain technique or a procedure to clean that out? Or is it just like whatever I can do to open this up right now?
Yeah, so you can just take it out because it depends. So I'm going to show you guys one right here. So I have one sitting here. So this disposable inner cannula, I'm going to kind of pull this pilot balloon away from it a little bit. This disposable inner cannula, and it's nobody should be faulted for missing this one because look at this one. Like you can, let's see if I can get it to
I feel like
focus
every
there.
episode we're trying to get this thing to
I know, man, dude. We should just use some pictures. I wish I could get that to.
just don't look at the camera for a minute. Oh, there it
There
goes.
we go. So if you look at that, I mean, you are inside. That thing is inside of that 15 millimeter adapter. So, I
Yeah.
mean, when you look at that, you have to pinch this thing and then pull it out. And so it's not obvious. You could put a bag valve mask over this, or if they have a speech valve, you take the speech valve off. It's like, are you going to notice that little thing, in the midst of the call? It looks like just part of it, but yeah, you can squeeze it and you can just take this little thing out. These always caution do not reuse. And a lot of them will say like do not reuse. But here's the thing, I would rather clean that thing out. Maybe I can force, I can take this thing out, quickly clean it out. Maybe I can pass, I can really be rough with a suction catheter or do whatever I have to do to clean this thing out. Maybe I even take it over to the sink or something like that. Because here's the thing, I really don't want to care for that patient without this in there because it's more risky. So let's say I take out the obstruction, they get a mucus plug. This thing is like full of garbage, and I take this thing out. They get some relief, and I'm like, oh, thank God, we fixed the problem. So I take this thing, I toss it in the trash, and then it happens again. They have this productive cough, and now they get more stuff in there. Maybe it's even thicker this time, and then I'm trying to suction it. So I always want to put one of these back in because you can just swap them out and swap them out, swap them out. That's an important thing to be able to do. So if you have to, you should really clean it though. Like I know it's dirty when you take it out, but you've just exposed it to like other kinds of trash. So the official answer is never reuse one. The practical answer is if you don't have another one, it would probably be more dangerous to not have it in.
Yeah, I would like take some of that sterile water that we always have
Mhm.
in the ambulances, dip that little
Yeah.
daddy in there, do some little
Yeah.
spinnies on there, and
Yeah.
and then take some gauze and just clean it all out. But what I like
Yeah.
about that one you just showed is you can still ventilate the patient once you take that inner cannula out. When
Mhm.
you look at something like this, you
Mhm.
can't connect anything
Right.
to the trach afterwards.
Mhm.
So I like that the one you just showed because
Yeah.
that inner cannula is not the thing that's making you able to connect the 15 millimeter adapter and be able
Yeah.
to provide ventilation.
Yeah, that's pretty nice. Yeah, I do like that feature. So this one is a Shiley. This is just a regular one. I don't think that I think this is kind of their default uh type of a trach. Like these are pretty common where that inner cannula is not part of the 15 millimeter adapter. These are super super common. So this is one you'll definitely notice. It really, like, if in their room you should be able to find a whole mess of these inner cannulas because they're supposed to be changed out daily, sometimes even more often. So there should be a stash of these things somewhere around. And something else you can do if there's like a bunch of equipment around is when you look at these boxes. I didn't mention this in the blog, but you guys can see this is green right here.
Yep.
All of these with Covenant, Shiley, Shiley brand, and the Portex brand, they're all color coded. So if something is green, it goes with the green stuff. If something's blue, it goes with the blue stuff, and just so on. So you should be able to quickly identify, like, okay, that's the accessory that goes with this particular trach.
That's cool. So you hold that up again.
Yeah.
Um, and you're mirrored. No, not that the package. There
Oh,
was
package.
that CN on there that stands for cuffed.
Oh yeah,
What
is
is
it coming through backwards on
it is,
the
but it
actual yeah.
it
So
says
yeah,
on
it says 4CN65H. And so it's like, what in the world does that mean? So 4 is the Jackson size, and I know this is mirrored, so I should probably stop showing it. 4 is the Jackson size. CN means that it has a cannula in it. Or no, I'm sorry, that's
a
cuffed.
cuffed.
6.5 or 6.5, you just have to pretend there's a decimal in there, so that means it's a 6.5 size. So out of anything, that right before the last letter, that's the most important number because that tells you the size of it. And so 665 is a 6.5. And then H at the end, it's not super, it's not of a lot of consequence to us. H means a disposable intercannula, and R means a reusable cannula. It,
We're
it
gonna
doesn't
reuse
really
it
matter if
anyway, probably,
yeah,
right?
we don't care which one. As long as it has ones, we don't care which one it is. I do wonder sometimes, like, okay, R is for reusable. Why is H for disposable?
I don't know. Maybe
I don't know
they
either. Isn't that a weird, like, wouldn't it be a D for disposable, R for reusable, D for disposable, but it's an
yeah.
H? No idea why. But anyway, that's what
I'm
the
trying
H
to think of
means.
why right now. What's the N for cuffed?
Mm,
CN?
CN. I put the picture in here. I know
Yeah.
that's a cuffed. Where did the picture go? I put it in the blog for deciphering those codes. No, I didn't.
But yeah, I mean, it says a cuffed makes sense and a U for uncuffed makes sense, but I didn't know what
Oh, wait, here it is.
the N stands for.
Yeah, cuffed is CN and then uncuffed is UN.
I don't like it.
Don't know. Don't know. These letters aren't making a lot of sense.
No,
So,
but you did talk about how to tell what size suction catheter you can use
mhm,
by
yeah.
timesing it by 2 and then going down one size, right?
Yep. Yeah. And so that works for ET tubes as well. So yeah, if it's a size 7, double that's 14, and you just go a size down on your suction, so you'd use like a 12. And that works for yeah, endotracheal tubes, tracheostomy tubes, whatever.
And then you want to measure it down to the sternum.
Yeah, that's the official way. I don't feel like a lot of people do that because they're just pretty much trying to go just a little bit beyond the tracheostomy because that's if it's occluding it, it's going to be kind of close. So I feel like it's mostly eyeballed. But if you wanted to get like, if you were curious how far you could go down, you're that's what is generally recommended from the tip of the tracheostomy to the neck, and then and drag it down to the sternal notch, and that's about. I don't want to say it's like the max. I'm sure people shove them down there or they go kind of shallow, but that's like roundabout in the middle, I guess.
Got it. All right. And then we have the laryngectomy. And I think sometimes it's hard to wrap your head around like how your mouth can't be connected to your lungs. But this is
Yeah.
this is a pretty good picture here. You can see how they literally just take the trachea and reroute it to
Mhm.
the neck. So there's absolutely no connection between the mouth and the trachea.
Yeah. Um, those patients are typically maybe like cancer patients or something, like if they have throat cancer, like that's generally it, or there was some kind of crazy trauma or whatever. Or maybe they had like, an inhalation injury where the vocal cords were so burned or so, it's something weird, pretty crazy probably happened, or cancer. And so now the trachea, yeah, is completely rerouted right above pretty much a sternal notch right there. And it's a pretty low and a big opening because now it's not just a slice in the trachea anymore for a tracheostomy tube. We're talking about literally taking that thing and like bending the trachea out towards the outside of the body, which is gives you a pretty large aperture to work with. I mean, it's the whole trachea, and so they don't put tracheostomy tubes in there. They have something called a Larry tube.
I don't know why that cracks me up.
A Larry tube.
Just
It sounds like
imagine a stressful situation. You're like, grab me the Larry tube.
yeah, it sounds like something you'd like use in plumbing or something.
Mm-hmm.
Like give me the Larry tube. It sounds like something you'd use on your toilet or something. But
Yeah.
which is funny too because you can do a tracheal bronchial toilet, which is the suction term for like going down and
So it
getting
kind of
all the
is
way to the
a
trachea.
plumbing term.
Yeah. So so with those ones, yeah, they eat, drink, all that stuff through their mouth, but there is no connection from the trachea, which you're right is a very strange thing. Like imagine taking a breath, and you're like your mouth and your nose never get dry. It's weird, very strange.
You'd probably still get bad breath though, because that's coming from your
Mhm.
stomach.
Yeah, yeah, probably. And the acid reflux. Yeah, that would be interesting. But
I
if
was
you had
thinking.
GERD, it'd actually cure the respiratory aspects of GERD.
Mhm.
It
I
wouldn't
was
be able to go into your lungs anymore.
Dude, I was trying to find a picture on Google of what it would look like if you were performing laryngoscopy and you flip that open,
Oh.
like what would that
Mhm.
look like? It would just be like nothing there.
Yeah, that's an interesting question. I've never seen a picture from that view.
And if
Yeah, that would
somebody
be
tells you
interesting.
that can you imagine somebody, "Yep, I intubated them," and then you find out it's like
A
a
laryngectomy
laryngectomy.
patient. Well, that must have been a very difficult intubation. But yeah, I think I put a picture of a Larry tube in the blog, and they're big. I mean, they're like big funnels
Mhm,
essentially, and they just sit there. And usually they just have like a big button on the front that's a humidifier or something, and that's what they do. And those are usually the patients too that have those voice modulators. If you've ever seen somebody put a voice modulator up into underneath their chin, and they speak through it, those are usually laryngectomy patients that have that very low. Um, uh, it's not technically a tracheostomy.
a la a Larry
It's a
tube.
trachea. It's like it's a laryn. I don't know, but those are the ones that technically or usually use those speaking devices.
Yeah, so let's talk about those speaking devices because those are interesting. Here's what we're gonna do. I found this video, and
Mhm.
I want to show it to you, and I want to see what you think. So there's something called the Green algorithm or Green protocol by the
Mhm.
tracheostomy emergency algorithm about
Sounds
how
pretty
to.
official.
Yeah, well, it's from the UK, and they had a video where they show like the steps that they go through when somebody
Mhm.
has a trach emergency. So I'm going to share my screen. If you guys are listening to the podcast, then you're just going to have to actually let me move this over. You see my screen?
Yeah, you're screen sharing.
I'm going to go to the actual. If you guys are just listening to the podcast, you got to go to YouTube and watch this. But yeah, this is it. This is the here. Let me move our cameras up a little bit. There we go. So this is the tracheostomy emergency algorithm, and there's like a protocol. There's an algorithm down here, and this is like the video of like what this looks like. And there's a couple things, including the thumbnail that we're looking at here, that seem just a little bit weird to me. And so I'm going
And we're
to.
not dogging on them. We're
No,
just
we're
doing a
not
little. This
dogging
is
on them.
like, is this technically our first like reaction video
I
ever?
think it is. Yeah.
I like the direction this is going.
Yeah. And I don't know. Am I doing this? Like, is this the best view or is that better?
That shows all the sides, so I feel like we should go with that one.
All right. Let's do this one. All right. And you probably won't be able to hear it. I don't think so. But
Yeah,
we'll tell
screw the
you.
sound. We'll just
Yo. All right. So obviously, somebody in respiratory distress with a trach.
and they got a speech valve on.
Yeah. So you can see the speech valve. He takes this little thing off the wall. It's got the little algorithm on it.
Yep, laminated, and so he's checking his algorithm. And the very first thing he does, let's pause right there.
Yeah.
At the exact right spot. So here's the thing: if a patient actually has a speech valve, I don't have a problem putting my. So at this point, I don't have an issue with this putting my. Well, at least sans COVID and stuff like that. But
Yeah.
generally, like if they have a speech valve, I don't have an issue putting my face next to it because a speech valve, just for those of you guys who are not too familiar with those, it's a one-way valve. So it allows air in, but it does not allow anything to come out. And so at that point, that patient cannot shoot anything at you. You cannot get, man, because that's kind of crazy. Like he's not masked, anything like that. He's got glasses on, but no real eye protection, no ear protection, which is a
Right.
strange thing to think about. But like if that speech valve wasn't on there, he's exposing himself, his face, and he's breathing that in. That's a lot to handle. So yeah, those speech valves, just for the guys, it lets air in, but when they breathe out, it doesn't allow it to come out of the tracheostomy, so it goes up through the glottic opening so that they can phonate. So that's why some patients can talk when they have these in, is because the air leaves through their vocal cords, not through the tracheostomy.
And most likely that means that it's also a fenestrated one as well, right? So
Yeah,
that way
yeah,
they don't
that's
have an
very
airway
common.
obstruction.
And if they have a cuff, it's usually deflated when they're using the speech valve as well. And some patients even keep like a syringe around in their pocket and stuff so they can inflate, deflate their own trachs, put a speech valve on, and they're very good at handling it.
All right. And I don't see a cuff on this one. Maybe it's
Right.
on the other side, but at this point, we don't see a cuff.
Correct. Yeah, no pilot balloon hanging off. So that's a good doorstep assessment. I got a speech valve. I've got no cuff, and I've got somebody in respiratory distress. So at this
All right.
point, he's putting some oxygen on that trach mask, or I mean, a trach mask on that trach.
So she should be able to get that oxygen. It should be able to come in because with that
Mhm.
speaking valve, you're able to come
Mhm.
in, but just not out.
Yep.
Would you be able to apply some of that oxygen to a mouth as well, please?
So he just told her to apply some oxygen to the mouth as well.
Yep. Which makes sense in this patient, which might not be something that we initially think about. But if the patient has any communication with their upper airway, then it's not silly to put an actual like face mask on somebody who has a trach. Like that makes total sense, especially if they have a speech valve, no cuff. Like that makes total sense because otherwise, if the patient's getting air from two sources, trach and mouth, then they can really dilute the amount of oxygen that you're giving them. So that's a smart thing to do.
And I do think like maybe if you didn't know if this was a laryngectomy or not, I mean, the speaking
Mhm.
valve would probably be a dead giveaway that it
Yeah,
isn't.
yeah, that would be. That's a good point. Yeah, so if the patient has if they have a fenestrated trach, if they have a speech valve or something like that, you can automatically assume that there is some communication with the upper airway.
All right. So he puts both of these on. And now he's saying to actually remove that speaking valve.
Yeah. So what they're trying to do here is they're essentially trying to eliminate one piece of equipment at the time through a process of elimination to see if they can tell why is this patient not moving air very effectively. So then he's like, "Oh, remove the inner tubes." The inner cannula comes out, and right there, that's that fenestrated tube. So we notice two things with this. One, the connection for a bag valve mask is connected to the inner cannula. So that's the first thing to note. Second thing to note is it is fenestrated. So if you try to bag that thing, it will also go in the chest and it will also come out of the mouth. So bagging this patient through that stoma, unless you covered their mouth, wouldn't be very effective.
So he removes that, and we don't see any obstruction. We don't see any gunk on it or any
Right.
phlegm or anything, right?
Mhm.
So, but they've removed that. Now they have that oxygen just over the cannula, right?
Yeah.
The actual.
Yeah, and I think that he just put his face next to that patient without having the uh the oxygen totally covering that thing. That makes me before it was cool 'cause you got a speech valve and whatnot, but and it's really not blowing at you. But if there's not something covering that trach, I'm incredibly uncomfortable putting my ear or face next to it because all it takes is one good cough, and even if it's not a huge obstruction that comes out and hits you in the face, you're getting exposed to a ton of particles at that point, ton of droplets.
All
Yeah,
right.
so
So now,
now he's like, okay, let's try to suction this thing. So they've got the inner cannula out. That's good. Remove that, and then he's going to pretend that he can't advance it right here, even though it's clearly beyond the tip of the tracheostomy tube. So they attempt to pass a suction catheter, and nothing came out. So now he's listening again. Saturations still suck.
yeah, and you have to wonder where this end tidal CO2 waveform is coming from because
Yeah, and all of a sudden it changed from a square waveform to a bronchospastic waveform with uneven alveolar emptying. Just like all of a sudden it created a quote unquote shark fin waveform.
yeah, and I don't know where that's coming from because it didn't look like there was a nasal cannula prong on or something, that would be coming from her mouth.
No, maybe the trach is fitted with one. I don't know. I've never seen something like that before, but I don't know. It could be maybe that's a thing. So now they're going to take this tracheostomy out. And this patient must be a long-term, very long-term tracheostomy patient. The speech valve and the fenestrations also give us that impression. If the patient has a speech valve fenestrations, this is probably not a trach that was put in last week. If the patient has received a trach within the past 1-2 weeks, like you should be very nervous to pull that tracheostomy out, because those things can close really fast. And with those like skin flaps over it, and kind of like almost like that Z tracking type motion of skin versus trachea versus tissue, you can lose that opening pretty easily.
Yeah, and you're taking away your ability to connect positive pressure ventilation as soon as
Yeah.
you remove. I mean, no, you're not, but through like a ventilator, because otherwise you're just going to have to put a mask over that or block that off and ventilate through the mask or through the mouth.
So here's a confusing part: is they take that tracheostomy out, and I understand that it's a simulation, but there was nothing in that tracheostomy. So you have to wonder where was like the obstruction from? Why couldn't he pass the suction catheter? Could it have been that it was just up against the tracheal wall and just needed to be a little bit,
Yeah, I'm
you know,
just,
positioned a different way?
yeah, let's see. Let me go back to where we are. I was going to try to get to that point to where, yeah. So there he's putting just a, there he goes with that ear again.
Yeah. Yeah. So now they've opted to cover the stoma, and you can do that with gauze, a gloved hand, a Tegaderm if you want. But you are covering up a hole that they breathe out of, so just keep that in mind when you do
Yeah.
that. So they opted to go right towards the upper airway here and to bag this patient with a closed stoma. I suppose if the patient cooperates and there's no upper airway issues and stuff, I mean, that's something you could certainly try. I don't think it's a bad thing, but it seemed like they had a good. If you can't identify an issue at the trach, I don't know why we go to the head right away. Maybe this is like a least common denominator thing where you just eliminate stuff and then go straight towards what they have left for anatomy or something. But I personally would have troubleshot that trach more, because there's less things between the lungs and the trach than the upper airway and the lungs. And so I want to give the most direct track. So I probably would have either at this point, if this patient was this bad, put in a different trach, clean out the one that they have, something like that. I would probably still be troubleshooting trach at this point, personally.
Yeah,
But
I agree. And I would put the end-tidal CO2 cannula right over that 15 millimeter adapter and place that on so I can actually see if we're exchanging air. Because we saw that uneven alveolar emptying, that shark fin waveform, which just means that while they're exhaling, there's a delay in that. So that could be from a secretion or something that's
yeah,
further down the line. But at least that tells me it's patent. You know, if I see end-tidal CO2 waveform, I know that I'm not clogged up somewhere down there. And at that point, you know, you got to wonder, well, do I need to inject some saline? Do I need to loosen up these secretions?
yeah.
You know, what do I need to do at this point? But removing that whole thing and trying to ventilate through the mouth now, like you said, there's way more obstructions that go from the mouth to the lungs than from the trachea to the lungs.
Yeah. I would have liked to just put a cuffed trach in right away and then just bagged through that. If I didn't do the saline first. And so now they're showing us different ways of bagging this patient. Now, here's something to keep in mind. This is not something mentioned in the video, but for this to work, that patient has to be consciously keeping their upper airway closed. So they have to be cooperating with you. And just like, we would, close our upper airway to hold our breath, that's essentially what you have to have that patient do, because otherwise, that breath that they're going to administer, so they're using a little pediatric or infant mask to fit over the stoma, or in a second, they'll use a supraglottic airway as kind of a little cuff or a mask. But yeah, if the patient's not cooperating, this is essentially same instance that I ran into with that coded patient, is that when you ventilate this patient, it's going to come out of their mouth and their nose.
And the nose. I mean, you got to clamp their nose too.
Yeah. So you'd have to almost act like you're killing them. Like you got to.
A pillow probably would work.
Yeah, and then it's just going to go up into their ears. So you got to plug their ears.
Ridiculous.
So, yeah, you got to essentially put a bag over their whole head to get this stuff to not come through the mouth. But if they're conscious and you're like, okay, do you know the drill? You got to close your upper airway. If that's a thing, then what they're doing would work.
So
But
that's an LMA right there.
Yeah, and that's pretty clever. Like if you're going to
Yeah.
do that, or let's say the patient has a Larry tube or something like that, or a different type of stoma, or has no upper airway, and has had a laryngectomy. That would be a something you could absolutely do. I think it's easier to just pop what they do in right here is intubate that stoma with a 6, because that seems like it would take a lot less time and eliminate a lot of problems.
Yeah. I agree.
They do note in here use of a bronchoscope, entry catheter, bougie, that kind of stuff. And I really cautioned in the blog, like if you're gonna use a bougie, you're anticipating, because then the tracheostomy is clogged. You're anticipating that you're going to have issues, right? You're thinking, okay, I couldn't pass a suction catheter, so I'm anticipating when I put this bougie in here, there must be something that's screwing it up, So you're already priming your brain to think I'm going to have to push hard on this. Well, you could be pushing hard right through a tracheal wall, so you want to really be careful for that. False passages, creation of false passages, perforating it is real, and that causes a whole nother set of issues.
Awesome, man. All right. Well, go check out the blog. Hopefully we don't have any hate mail coming from the UK. Not dogging on this video. At least they made a video for us to do this, because I actually think it's helpful to go through this and actually build a mental model of what these look like. And I think that video actually helped really augment some of the stuff that we talked about early on in the podcast.
Yeah, they have that algorithm to check out for sure. I have different algorithms in mine. It's not exactly the same thing. They're kind of talking about general troubleshooting. I made 2 algorithms. One was strictly about clearing the tracheostomy, like if you're going to keep it in, like how to troubleshoot clearing it. And then the other one was was a decision tree essentially of, can I ventilate this tracheostomy or not? And it goes through, what if it has holes in it? What if the cuff doesn't hold pressure? And so that's something to just take a look at and keep, because if you can't ventilate it, you want to know pretty quickly if the patient's crashing.
Absolutely. All right. Any shout outs? We got anything coming up? We got that content creators workshop for FOAMfrat Studio. So what we wanted to do is like get the people that are in FOAMfrat Studio, who are like training officers, directors, and get them all together and show you how to create content best suited for studio. So that'll be coming up on December 5th or 4th. I can't remember, but we got put a bunch of stuff on it. It's on Facebook. All right, man. Great post, and we'll see you next week.
See you guys.